chairperson, Dr. Sai Krishna Vittal, my close friend. I think he is one of our ambassador of Royal College of Surgeons of Edinburgh. He has been the examiner for both for our MRCS and also for FRCS, and he has conducted various courses. He is conducting regularly the exam in Chennai, and he has been a council member. I know he knows every stone in the building right in Edinburgh. He is so well versed. I'm sure Professor Griffin also will know the efforts he put in for promoting the all the activities of Royal College. I request Sai to take the pleasure of inviting his good friends. That way we'll interact, like Venkat and also the Jambulingam if he already joined. Over to you, Sai.
Thank you, Ishwar, for your kind remarks. Am I audible to start with?
Yeah.
Thank you, Ishwar. It's indeed pleasure to join you in this conference. Although I'm a core endocrine surgeon, thanks to you and because of you, I have sort of agreed to be a chairperson. I have the pleasure of saying a few words about two of my good friends. Start with Venkatesh Shanmugam, who had his undergraduate from Tanjore Medical College and he did MS along with me from Madras Medical College. Subsequently, he had higher specialist surgical training in colorectal surgery, and he is currently a colorectal surgeon at the University Hospital of North East and Hartlepool, and he is quite into colorectal surgery, does a lot of he's got a lot of aptitude for training, and he has done a lot for training in colorectal surgery in the Northeast. Along with me is also one more good friend, Dr. Jambulingam, who's once again alumnus of Madras Medical College. If I'm not mistaken, he was 2 years my senior in MBBS. Subsequently, he underwent higher surgical training in the UK, and he's currently an upper GI surgeon and is attached to Imperial College London, where he serves also as the honorary clinical senior lecturer. Is Jumbo on the line as well? Has he joined?
He'll join, but I request you to also brief introduction about Dr. April Roslani. She is going to do the presentation first. I know her through you only. She is joining now live, and she's waiting to hear from you directly.
Oh, really? Okay. April Roslani, first of all, a very good friend of mine. She's a consultant colorectal surgeon based in University of Malaya, Kuala Lumpur. She is currently the president of the Malaysian College of Surgeons, and many of you may not be aware that she was awarded the honorary fellowship of the American College of Surgeons last, I think a week or so ago. In fact, I think there was 7 or 8 people who were awarded honorary fellowship, and she was the only woman, and I think she deserves a big applause for that.
Thank you, Sai. Let us go to her presentation straight before we go for further interaction. Can we go for her presentation on laparoscopic management? I think she had a very interesting topic. We had in the morning also discussed how to manage leaks in the large gut.
Thank you to the organizers for the opportunity to speak to you today regarding endoscopic rescue of anastomotic leak. These are my disclosures. Anastomotic leakage is probably the most dreaded complication after anterior resection, with an incidence ranging from 1 to 24%. Risk factors include distal rectal anastomoses and following neoadjuvant radiotherapy and/or chemotherapy. More recently, interactions between the microbiome and the host response to surgery have also been implicated. Unfortunately, the mortality rate can be as high as 22%, particularly if rescue is delayed. While attempts at producing algorithms for the management of leaks have been undertaken, essentially, treatments should be tailored based on location, clinical presentation, radiologic findings, patient factors, and availability of resources. The case being presented today was a 66-year-old female who was diagnosed with a locally advanced rectal carcinoma. She had undergone neoadjuvant chemoradiotherapy. Subsequently, an open ultra-low anterior resection with J-pouch reconstruction was performed with defunctioning ileostomy. However, on postoperative day 5, she developed acute onset of tachypnea, tachycardia, and abdominal distension. Following resuscitation, CT scan confirmed the presence of anastomotic leak with a pelvic collection. She underwent examination under anesthesia. A posterior defect 2 centimeters from the anal verge was identified. The subsequent laparotomy and washout was performed, and an endosponge was applied. Endosponge is an endoluminal vacuum-assisted system comprising an open-port polyurethane sponge, an overtube and pusher, and a low vacuum suction bottle. The sponge itself can be trimmed to fit the cavity snugly. Following endoscopy to determine the location and depth of the abscess cavity, the overtube is endoscopically placed. The endoscope is withdrawn and the endosponge inserted through the overtube using the pusher. For larger cavities, multiple endosponges can be placed concurrently. The tubing is connected to the suction bottle and the vacuum activated. This allows active drainage and the gradual filling of the abscess cavity with granulation tissue. This is a short video to demonstrate the insertion technique. Endoscopic assessment of the cavity is performed first. The scope is then withdrawn and the overtube is placed endoscopically. Following placement of the overtube, the scope is withdrawn. The endosponge is then inserted into the overtube and placed into the abscess cavity using the pusher. A mark on the pusher defines the extent to which it should be inserted. The overtube is then removed and the endosponge tubing is connected to the suction bottle. The vacuum can now be activated. 2 levels of suction are available. The tubing should then be secured to the patient with tape or sutures. Sponges should be changed every 3 to 4 days and may need to be pre-moistened to ease removal. After 2 endosponge applications, CT showed a smaller pelvic collection but a residual abdominal collection which was drained percutaneously. This is the sagittal view. She had a further 5 endosponge applications, and these endoscopic images show the gradual resolution of the abscess cavity. Subsequent CT showed complete resolution and she was discharged well. Over a period of 2 years, we used the endosponge in 6 patients using 27 sponges. The patient discussed earlier declined adjuvant chemotherapy despite the risks of recurrence and ultimately survived 31 months following surgery. 2 other patients had delayed presentations but responded well to endosponge therapy and remain well more than 3 years later. We have also used endosponge in a palliative setting where it provides superior control of externally discharging endoluminal fistulas. In a recent meta-analysis of 17 studies, 276 patients were analyzed. The weighted mean for successful healing was 85.3% over a median duration of 47 days. The weighted mean stoma closure rate was 75.9%. Thus, it can be concluded that endosponge has a high rate in complete healing of anastomotic leakage and stoma reversal in selected patients. In summary, management of anastomotic leaks needs to be tailored. In selected patients, endoluminal vacuum-assisted therapy can salvage low rectal anastomotic leaks, thus avoiding the need for further surgery. Thank you.
Thank you, Dr. Roslani. It was really nice, innovative, cost-effective. But is it really effective? I want Venkat's view from across UK. Being a colorectal surgeon, I understand your view, sir.
Thank you very much, Dr. Yeshwamurthy, and thanks, Dr. Roslani. It's a very nice demonstration of the endosponge. He's now looking into trying to implement as a guidelines for endosponge, which is not being taken up very well in the UK. I have used a couple of times, so it is a very good tool. It's just I assume that this patient had long course chemoradiotherapy, defunctioned already as a primary surgery.
Roslani, would you like to answer that? She was there, I'm sure.
Hi everyone, can you hear me?
Yeah. Go on.
Yep. So the case that was presented, yes, the patient had a defunctioning ileostomy. Despite that, she developed this pelvic collection, and when she was taken to theatre for the EUA, the defect was quite large, and I think that's the important thing. If you're going to insert an endosponge, usually the defect has to be quite large, otherwise you would actually have to make the hole bigger in order to insert it. So as you saw from the data we presented, we've only used this in a few patients, and I think that's the limitation. Not every anastomotic leak can be managed this way.
Yeah, that's what my next question was going to be. So what is your indication, and more often contraindication for the viewers? What is the contraindication for using endosponge?
Yeah, so obviously if the patient has got peritonitis, I mean, this is somebody that you can't manage just with a local therapy. You probably need to take the patient back for re-exploration. But if they are relatively asymptomatic, or the symptoms are confined to the pelvic area, and you suspect, or as in the scan that was shown, the defect is quite large posteriorly, this would be someone who is ideal for endosponge. You will also note that the other 2 cancer cases that we had, they were quite delayed presentations, again because they already had stomas, but they presented nearly 3 weeks down the line, and again, just very localized symptoms, and this endosponge treatment allowed faster, I believe, resolution of the cavity, and allowed the stomas to be closed subsequently.
Thank you, April. I think the time is up. Venkat will go on to the next one. I think Dr. Murugan is waiting for quite some time. April, nice coming all the way, and your presentation is really excellent. We are going to see in few patients, and I'll get back to you with the results. Over to Dr. Murugan from Malaysia.
Good evening, ladies and gentlemen. First of all, I'd like to thank Royal College of Surgeons Edinburgh, and also IAGS India for organizing this wonderful workshop. I'm Murugan from PENANG Adventist Hospital, is a northern state in Malaysia. So I'm going to talk about ERCP in surgically altered anatomy. So basically, ERCP in a surgically altered anatomy is very challenging because of the many alternative techniques available for many different types of reconstruction. And compared to the normal ERCP in normal anatomy, in surgically altered anatomy, the number of cases is actually quite small, and it's really need a well-experienced endoscopists who are well versed with the various accessories and various type of diseases. So the challenges are mainly three: mainly assessing the afferent limb in different types of reconstruction. Once you reach the papilla, we need to cannulate the papilla, which is already altered in orientation from 11 o'clock become 5 o'clock. This is a reverse orientation. And with that, we need to perform various therapeutic intervention with uncommon endoscopic accessories. And we also have other challenges like limited maneuverability caused by angulation of the anastomosis, looping, adhesions, and also difficulty to differentiate between afferent and efferent loops. So the successful cannulation in surgically altered anatomy depends on the now whether we can assess the papilla, availability of the various endoscopes and accessories, the expertise of the endoscopists and the team, and finally the effective therapeutic interventions. So the endoscopist must actually well versed with a normal anatomy first, and he or she should be able to perform various advanced therapeutic intervention before embark on the ERCP in an altered anatomy. So the endoscopist must be familiar with the freehand needle knife intervention, various sphincterosome, the guide wires, balloons, baskets, and so on. And the room, the fluoroscopy room is adequate as for the normal ERCP. Need to have a fluoroscopy machine, the video monitor, side viewing scopes, forward viewing scopes, X-ray monitor, and so on. The first step for the intervention is actually the endoscopist must know the types of surgical surgery done, and he need to talk to the surgeons and also look at the post-operative notes and well versed with the reconstruction made. For example, in the case of esophagectomy and with the stomach pull through, the stomach will be in a cylinder shape and is quite straight and short. So in this type of surgery, you just need to use normal duodenoscope. However, because of the very close space between the scope and also the papilla, the intervention can be difficult. So we need to maneuver the duodenoscope to distance the space between the tip of the duodenoscope and papilla for intervention. And the endoscopist also must well versed with the various type of gastrectomy, isoperistaltic, antiperistaltic, retrocolic, anticolic, brown anastomosis, and so on. And the endoscopist also must be well versed with the various types of Whipple procedures, bariatric surgery, Roux and Y bariatric surgery, duodenal switch, and so on before embarking on the ERCP in surgically altered anatomy. So for short afferent limb, where the anastomosis and the papilla is usually less than 50 centimeter or the most is 70 centimeter, the success rate of performing ERCP with the conventional duodenoscope or gastroscope or coloscope is actually quite high. For long afferent limb, where the anastomosis may reach 100 or more centimeter, for example, in bariatric surgery, assessing afferent limb can be challenging, and the success rate is slightly lower when you use a conventional endoscope. So we need to use long colonoscope or duodenoscope. In this patient with the Brown's anastomosis, with the previous Roux-en-Y anastomosis, I use a forward weaving scopes, and we slowly withdraw to check the afferent loop or efferent loop. Sometimes we need to tattoo the afferent loop. We need to use a CO2 inflation to reduce the abdominal bloatedness, and we need to slowly withdraw the scope and with the minimal insufflation, and we need to check where the afferent loop before further intervention. So in this position, and then we can find the Brown's anastomosis. Then we can actually introduce the scope into the afferent limb for further intervention. So the second prerequisite is actually selection of the optimal endoscope type for different type of reconstruction. For short limb, afferent limb, we can use a duodenoscope, gastroscope, or colonoscope with or without cap fitting. There's a higher chance of perforation if you use a duodenoscope with a limited visualization, and because of the difficulty controlling the scope, and also the need to apply more pressure to overcome looping. So in this case, I usually use a forward weaving scope to assess the papilla for intervention. Sometimes I use a guide wire to guide the duodenoscope into the afferent limb to assess the papilla. For long segment scope, for long segment limb, we can use a double balloon enteroscope, single balloon enteroscope, and endoluminal ultrasound. Or also we can use a laparoscopic assisted ERCP, which have a high success rate. If you use a normal conventional scope or colonoscope, the success rate is actually lower. So the third step is actually cannulation of the papilla with biliopancreatic anastomosis. What we do, what we know is actually in a patient with altered, surgically altered anatomy, the papilla is actually in a different reverse orientation. So we have various endoscopic accessories such as Sohendra, Bilbrod, sphincterotom, rotating tip catheters, and so on for tackling the papilla. You can see here, upper part is a normal anatomy where the papilla orientation is at the 11 to 12 o'clock position. For Bilbrod 2 anatomy, the papilla orientation is actually reverse. It's at the 5 to 6 o'clock position. So, so we need to actually modify the accessories to cannulate the biliary tree. So in this patient, actually had a gastrectomy, then developed a biliary stricture with a CBD stone, underwent ERCP in Singapore. However, complicated with a perforated duodenum. Subsequently, he was transferred to PENANG Adventist Hospital. So he had a jaundice. So I used a forward weaving scope to assess the papilla. And you can see here the stone is removed. He had a bile duct stricture. So I use a sphincterotom, not easy to control. We need to groom the tip of the sphincter to assess the biliary tree. So once we assess, we remove the stone. So in order to tackle the stricture, I will insert a metal stent. So the papillary intervention, we have a various accessories such as S-shaped sphincterotom, rotatable sphincterotom, push-type sphincterotom, and freehand needle knife. So the same patient, I use a colonoscope to stand the stricture. We use a expandable metal covered stand which can keep for 6 weeks to dilate the stricture. So you can see here with the colonoscope, I'm inserting a stand for this patient, and you can see here the bile is flowing. So because of the colonoscope, there's no elevator. It's quite a challenge to treat this patient. Sometimes we need assistance from the radiologist who can perform percutaneous, transhepatic biliary drainage. He can insert a wire so that we can, from integrate, we can actually use the guide wire to assess the afferent limb and the papilla. So this patient had a stricture at the biliary tree, it's a malignant stricture. So we use a colonoscope to stent the stricture. You can see here the radiologist is helping me to guide the wire, and it's a long segment stricture. I use a metal stent to tackle the stricture. So you can see here post stenting, good flow of contrast shown. So for the success of the ERCP in a surgically altered anatomy, we need to have a good team, not just the experienced endoscopists. So good team is very important. And in conclusion, ERCP in a patient with a surgically altered anatomy requires high technical expertise, and we must be familiar with the various endoscopes and proper understanding of the type of surgery, length of afferent lip, proper choice type of endoscope use, and also use of compatible ERCP accessories are the key to success. With this, I end my presentation. Thank you for your kind attention.
Thank you, Murugan. And the time is up. I'll go straight to the next presentation. If we have time, we'll have a discussion because the panel, we have a couple of agendas to be filled in. I'll ask Dr. Chandran to present the EMR on colonic polyp. Chandran is one of my close friends. He is working in Wrexham in UK. So he is going to present now. Good to you.
Many thanks for inviting us to share with you our endoscopic mucosal resection of a rectal polyp. This resection was performed on an 85-year-old female who presented with colorectal bleeding and was found to have a palpable fleshy rectal mass on digital rectal examination. The colonoscopy examination confirmed 5 centimeter sessile polyp in the rectum. Magnifying narrowband imaging confirmed a type 4 pit pattern which resembles the gyri on the brain. We proceed by injecting EMR solution to raise the polyp away from the submucosal layer. Our cocktail consists of 40 ml of gelofuscin, 2 ml of 1 in 10,000 adrenaline, and 1 to 2 ml of indigo carmine dye. We inject the solution at multiple points at the base, enough to ensure that the polyp is sufficiently raised and to minimize the risk of perforation when resecting the polyp. As the polyp is seen to be raised nicely with no obvious tethering, it is reassuring that the polyp is likely to be benign. Once the polyp is adequately elevated, we proceed with the resection. The colonoscope is orientated so that the polyp is at the 6 o'clock position, and this is to allow better convenience while performing the procedure. We use a hot snare to resect the polyp. As the polyp is relatively big and there's no obvious narrow stalk that we can see, a piecemeal resection was performed. We try to incorporate as much tissue as possible during the resection. It is good practice to elevate the polyp tissue away from the submucosal layer before delivering energy to prevent any injury to the layers underneath it. This process is repeated until the base of the polyp is reached. Every attempt should be made to resect as much polyp tissue as possible before retrieving them to minimize the number of times the scope are being taken out and inserted in. This is to minimize the amount of discomfort that the patient can experience if the scopes are being taken out and put in repeatedly. when there are too many polyp fragments obscuring your view of the resection field, it is best to retrieve them to ensure that you can perform the resection safely. There are various ways that we can use to retrieve the specimens. If they are small enough, we can suction it out using the colonoscope with the trap at the end. If it's too big to be suction, we can either use the snare itself, as demonstrated in this video, or we can use an endoscopic net to scoop the fragments out. Once a better view is achieved, we re-examine the base of the polyp, and here we can clearly see there are some polyp tissue remaining. We continue the resection until the entire polyp tissue is removed. For the remaining polyp tissue at the edge of the base, we prefer to use the smaller size snare, which we feel allows a finer resection of that area. Here we are using the endoscopic net to remove the polyp fragments. Again, the base of the polyp is re-inspected and any residual polyp is resected. Any significant bleeding at the base of the polyp should be addressed. Here, we use a diatomy energy device connected to the endoscopic forceps to achieve hemostasis. The endoscopic forceps can also be used to remove any small residual polyp tissue at the edges of the base. Here we can see that the polyp has been completely removed and the edges of the base appears to be clean. A small residual polyp in the procedure, and the patient was discharged on the same day. We routinely perform a repeat endoscopic examination of the area 3 months post to assess for recurrence. Histological report of this polyp showed a benign tuberculous adenoma with low-grade dysplasia. Thank you.
Chandran and his team, I request Venkat Sanmuham his comment on the procedure, whether it's rightly indicated, and also April for her view on this. I think both of you, just a quick comment on this before I request Sai to introduce our next speaker. Yes, over to Venkat.
Yeah. Thanks, Dr. Ishramati. It's Dr. Chandran. It's a good demonstration. What is your view on doing an ESD in this kind of polyps or a TEMS procedure? That would have been
that is the ideal one. I think that's already there. We are silently agreeing. Myself, we were interacting. I think that would have been the first bet, because here there is high chance of recurrence, and it doesn't look good at the era. I mean, this might have been taken as the procedure 10 years ago, but now with the technology and the accessories available, I think you need to go for the one. So that's each surgeons are different the way they've been taught. I think Dr. Roslani, what's your thing? Anything else you would have done differently?
Yeah, no, I mean, being a surgeon, any sort of neoplastic lesion, I would like to try and remove it in total rather than piecemeal. But I understand that sometimes there are limitations in resources, and particularly if the patient is unfit for an anesthetic, etc. This may be something that will, at least address the immediate problems. But I agree with you. I think the recurrence rate is going to be pretty high in this particular resection.
Thank you for both of you sharing. I request Sai Vittal. I think Jambu is already there. He is going to give the comments at the end. But Sai, please invite our next speaker, Rajshekhar, the chairman-elect of ASI, the other side, and he is already starting his presentation. Yes, over to you, Sai. Unmute yourself.
Thanks for reminding me, Ishwar. It gives me a lot of pleasure to say a few words about my one other dear friend, Dr. Rajshekhar. Dr. Rajshekhar is an alumnus of Stanley Medical College. He did both his undergraduate and postgraduate from Stanley Medical College. He subsequently went to UK, had higher specialist training. He worked for a long time in Edinburgh. In fact, he worked with Steve Nixon, as in fact co-authored a chapter on laparoscopic splenectomy in Kirk's textbook of surgery. He is currently the chief surgeon, head of the Department of Surgery in Manipal Hospitals based in Salem. And as Ishwar already alluded to, he is going to take over as the chairman of the Tamil Nadu chapter of Association Surgeons of India. Over to Rajshekhar for his topic on rare foreign body esophagus tricks of the trade.
Thank you, Ishwar and Sai, for the nice introduction. I think the rare foreign body, which is rare for you, is going to be common for me. What is common for me is going to be rare. I think the principles are the same regarding the foreign body, whether it's going to be a rare foreign body or not. I think a history and imaging is at most important to decide whether we are going to intervene with an endoscopy and remove it. And adults, most of the foreign bodies can be removed by sedation. Some instances, ET is required. We need all sorts of gadgets to remove the sharp and other foreign bodies. These are some of the gadgets available. And this is the net where it's very useful for removing a food bolus obstruction or a very slippery foreign body, which had been shown by the previous speaker to remove the resected polyps. This something net from a porcelain model. So I would say upper esophageal foreign bodies, always I keep rigid scopy ready, because sometimes it's not possible with a rig. So commonest is a battery, because it causes caustic injury to the mucosa, and a lot of damage to the esophagus has to be removed as early as possible. And be very cautious. You can use alligator or a rat tooth forceps, or sometimes a snare, and gently pull it out. And most of the time coming out of the cricopharynx is a little bit tricky, where most of the foreign body slips, and just pull it out. So it's very important And sometimes you have to use a rigid, in this particular case, the upper esophagus, I have to use a rigid scope to remove the bigger body. Coins are common, but in this particular patient, a 15-year-old girl, when I put in, there were 2 coins sitting in the upper esophagus, which is not that common, but it's like a pasted together. And so here, you can try to use alligator forceps. The possibility is either I can hold 1 coin and pull it out, which was difficult because you can see they are totally stuck together. Separating them would have been difficult. So I tried my luck by holding both the coins with alligator forceps, and I could hold it, rotate and hold it, and gently pull it out. And in fact, the patient was surprised to see 2 coins. She thought she had swallowed only 1 coin, and she thought I had given her a change for 10 rupees, a 5 rupee coin, 2 5 rupee coin. So the 2 coins had been removed. Sometimes the coins are tricky. In this particular patient, being adult, 2 coins sitting in the upper esophagus and having symptoms, I have to remove them. Otherwise, majority would pass spontaneously. Food bolus obstruction, the common technique is a jackfruit, common in Kerala. They call it as Chakka syndrome. Some patients do present with even small bowel obstruction. The best technique is gently push it, provided you know there is not much of a stricture. So the food bolus had been pushed in, and you can see that amount of damage this food bolus has caused to the esophagus with a, excavating just an ulcer there. And sometimes we may have to remove the food bolus piecemeal using maybe a Dharma basket, or you can use a over tube, and make sure that there is, in the adults, particularly in this age group, there's going to be a pathology, either a stricture or a malignant growth which is obstructing. Sometimes you can pass the endoscope beyond, have a look, and decide whether to push in or pull the, remove the food bolus obstruction piecemeal. In this particular case, there was a esophageal growth with a food bolus obstruction. After removing all the food bolus, biopsy of the tumor was done. So one should be careful, particularly in adults, when they present with food bolus obstruction. There's usually a benign stricture or a malignant growth or some pathology which is causing the food bolus obstruction. Here is an elderly gentleman, alcoholic, who had been having dysphagia after having alcohol, but for 4 days he had been on alcohol alone. And with a typical history, I put in endoscope. You can see a chicken bone which has been, perforated on either side of the esophagus and got stuck. And I tried pulling it out, but unfortunately, it's not coming out. And if I pull it forcefully, it may injure the extend the perforation. So I tried rotating the scope and holding to one side. And likely, after trying for more than 10-15 minutes, one side I could pull it out, and the bone was removed. And these sort of cases, you have to go back and inside and see what sort of a damage it has caused. Ideally, when I put in the scope itself, I knew there is perforation on both sides. So we went in and saw that there is this is the bone with the anesthetist. Because this patient was alcoholic and in delirium, we have to intubate him ET tube. So went back, and you can see this perforation. That's a large perforation there, and the both sides are. And we got subsequently the post-op period, we got a CT scan. I put him on an NG tube, and there was no evidence of any mediastinitis or a local abscess. So we treated him with NG feeding for 5 days, and then gave him a contrast to see if there is any leak. After 5 days, there was no leak. Hence, the patient was started on oral. And there's another patient with a fishbone. This time, it is only on one side, it's pierced. This again, we can use a foreign body forceps to pull it out, and sometimes it's going very deep. Again, we need to look into the perforation, the anatomy of the perforation, and we have to look in whether there is any abscess formation in the through the perforation, if there is a leak, and then we have to address that with a CT scan, and if needed, treat them with a NG tube, and then follow up with a magnet. This case, particular case, the esophagus, when it was in the esophagus, so I pushed it into the stomach. Because it's very slippery, using a Dharma basket, I have pulled it out. Magnets, when the magnets are 2 in numbers. When they swallow, they can get attached to one another, particularly in the small intestine, and cause problems. Here, this is the common problem when we deal with the slippery, it slips in the pharynx. So you need to have the anesthetist who can very easily remove it. Here it's a tablet with a wrapper. It's very sharp, these wrappers are. There's one veterinary doctor in the train, he was going, he just accidentally swallowed and then got down and in Salem and came. So this is very, very sharp, which can injure the esophagus. So you have to remove it under vision. And the dentures are common. The problem with the dentures is most of them, they can get impacted. And the other problem is the metal attachments, which can cause, which is like a hook on either side or sometimes one side, which can cause perforation while removing it or manipulation. This sort of in the upper third of the esophagus. So sometimes if it is easy, we can push it inside the stomach and manipulate and remove it, but we should be cautious that we are not causing any iatrogenic injury to the esophagus. While manipulating with the Dormier basket, fortunately it slipped itself into the stomach, so I have adequate space to go inside the stomach, use a Dormier basket, pull it up. Whenever there's a metal object, it's always better to leave the metal object to trail when you remove it, so that it doesn't cause any injury to the esophagus while removing. Here I'm just using, there's not metal at the attachments to the denture. So this being using a Dormier basket.
You have 1 more minute, Rajshekhar.
Yeah. So that's being pulled. Again, the tricky part is bringing it out from the cricopharynx. And sometimes when in an impacted denture, it's going to be extremely difficult. If you incorporate such a situation, you have to keep your OT staff ready, anesthetist ready in case you have to intervene surgically to remove the impacted dentures. Here is such a scenario where the denture is so much impacted and I couldn't push it, so I have to do likely to the cervical esophagus. So that is, you can see we're doing opening up in the neck, and you can see that perforation, and the denture is popping through, and then extend the incision. We knew because of the previous CT that it has got this denture had a very single hook, which was very much curved. So we didn't want to injure the esophagus, gently remove it. You can see that denture with a hook. If accidentally, if I pull it, I would cause more damage. And the cervical esophagostomy was closed.
Thank you, Rajshekhar. I need to stop you here. Thank you. And Jumbo, your final word, because we need to interact with you at least for 30 seconds, having joined from UK. Jumbo, over to you.
It was a very good presentation.
Thank you.
I thoroughly enjoyed it. It was the whole gamut of upper third, middle third, and lower third. In UK, upper third goes to the ENT surgeons. We get called only in the middle of the lower third is involved. But it was good to see that the procedure was done safely. You had the anesthetic help available when needed.
Yeah.
Thank you all the chairpersons, and thank you Rajshekhar, thank you Sai for having brought everybody, all your friends on the podium. Thank you Dr. Govindraj. I think we are up because we have to finish all, and we are doing like a clockwise precision. The final one, we have only 35 minutes for a 36-minute session. So over to the debate, and we are going to have on the poem we saw this morning, whether the poem is the best or the Lapella. You wait to see with the judge, John Tanakumar, is taking the chair. Over to the debate.
Thank you.
Thank you, Ishwar.
Thank you, Ishwar and team. Thank you.
Thank you,
Ishwar. Thank you, Sai.
Pleasure.